Good afternoon. My topic very linked with the first line therapy and this maintenance therapy is ovarian cancer. My name is Yadira Kando. Continuous definition. Definition: it is and this is the which cancer cell developed in the ovary with divided underground uncontrollably. And continue my video.
It's known as the silent killer for women.
The problem with ovarian cancer is that the majority of women are diagnosed with advanced stage. So the mortality rate of ovarian cancer is much higher.
In the U.S. each year, 23,000 women are diagnosed with ovarian cancer. Doctors say the symptoms are few and many go unnoticed, like bloating, change in appetite, and indigestion. While there's no screening for ovarian cancer, if a patient is predisposed to the cancer, there are some new early treatments.
One of the new recent exciting things we have in the treatment of ovarian cancer is targeted therapies. So women that we know that carry the BRCA mutation or similar mutations are now candidates for targeted therapy for ovarian cancer.
Targeted therapy focuses on treating the specific mutation in the cells.
So this is an exciting step beyond the chemotherapy that just targets all the cancer cells or all the cells in our body, cancer and normal cells.
Doctors say targeted therapy is an option for women who are predisposed to ovarian cancer.
Women who have a strong family history of ovarian and breast cancer should be evaluated to see if they carry genes that predispose to those cancers.
If a patient is diagnosed with ovarian cancer, other treatments are chemotherapy and surgery. For Lee Health, I'm Lindsay Fry.
Belly, do you want us to start adding additional fluid?
Continue my YouTube video.
Everyone is working together to provide the best possible care so the patients can recover quickly and get on to additional treatment like chemotherapy as soon as possible. The chemotherapy includes, for many patients, IV chemotherapy, but some patients also are eligible for chemotherapy to be given into the belly directly. That's called intraperitoneal chemotherapy, and that's given for very particular circumstances, but is an important part of the treatment that we offer and something that is an area of particular expertise here at Northwestern.
Application is nursing. Surgery removal of the tumor is essential. Surgery mainly included the removal of the uterus and the ovary. On the local node, the other structure found in the intestine, peritoneum, urinary tract in there are also after. So the target was the intraperitoneal administration of the chemotherapy as it cell the best result. But in the case of the advanced stage ovarian cancer, in the intensive treatment and made in the short therapy. I continue my video.
So the rationale for the Veliparib trial was to evaluate the efficacy of the PARP inhibitor Veliparib in the combination chemotherapy phase as well as in the maintenance phase. And so the trial was set up as a 3-arm trial to look at that specifically. So the placebo arm, the control arm was essentially a chemotherapy combination paclitaxel carboplatin with a placebo given with placebo maintenance. And then there was the experimental arm, the arm that we're going to be reporting on at this meeting, was looking at paclitaxel carboplatin and Veliparib, followed by Veliparib maintenance. And so the third arm of the trial is essentially looking at the combination with Veliparib, but followed by placebo maintenance. So, but the primary hypothesis for this was that PARP could augment chemotherapy, and that's why we designed the trial the way it was designed. What makes Veliparib unique is that it has, from the characteristics that make PARP inhibitors do their action, their mechanism of action, there's two primary ones. One is the catalytic engagement of PARP itself, and the second is that it can trap PARP onto the DNA. And we think that Veliparib may be a relatively weak PARP trapper, and so because of that, it has allowed it to be actually administered or co-administered with chemotherapy that has cytotoxic intent. And so the unique thing about Veliparib is that it is one of the very few PARP inhibitors that can be given with full dose chemotherapy, and that's what we studied in Velia.
Pro and the cons. Pro and the cons menstrual disturbance, postmenopausis, blending, el pain cesar relación, stomach discomfort, sweat and the abdominal pain, problems when eating and the loss of the appetite, constipation or diarrhea. I continue my video.
I don't know about you guys, but I was very, very moved by those talks. Thanks to everybody who did that. I find it really hard to follow that. But while I was listening to what everybody talked about, I was trying to think about themes that they brought up that actually go along with what I'm going to talk about. And I think for me, as a physician and not as a survivor, there were a couple of themes that I thought resounded for me. One of them was finding the right doctor. And not just the smartest doctor or the doctor who knows the most science or the doctor who has the best lab. How do you choose? Well, I make a choice together with the patient based on her goals of treatment and where she is in her life and what side effects she is and is not willing to tolerate. So what one woman might have as her first line for her current disease might be very different than what another woman has. Do we do 2 drugs or do we do 1? Nobody really knows. And where does surgery fit in? We alluded to this a little bit earlier. I'm going to try and touch a little bit on all of these, but obviously we could spend all day talking about this. So if you have questions at the end, did Dr. Beer offer his email at the beginning? Yeah. You can please feel free to email me. You can find me online. I don't find email invasive. I'm addicted to it. So if you'd like to email me questions, that would be absolutely fine. These are my kids. They hate it when I do this. So my oldest daughter is the one with the long blonde hair on the left. She just graduated high school, which is making me feel really old. I have 4 kids, which people say is a little crazy. But anyway, they were synchronized skaters when we were in Boston. Does anybody know what synchronized skating is? Yes? It's kind of a really weird sport. It's when you get 20 skaters and you dress them exactly alike, they're supposed to look exactly alike, and they skate across the ice and they do beautiful, beautiful things. You're not supposed to be able to tell one skater from the other. So that's them on the left, supposedly looking exactly the same. And then on your right, you can see that they're actually 2 very different, oh my God, very different human beings who look very different. And I use this example, and I know Dr. Beer talked about this earlier. This is a very simplified version of what Dr. Beer said. All ovarian cancers are not the same. And not only that, if we take the most common ovarian cancer, the serous subtype, and I show you 2 photomicrographs of what they look like under the microscope, they look exactly the same. But if we look at their genes, as Dr. Beer told us, they look wildly different. And so we really can't expect one cancer to respond to treatment in the same way as another one does. You just can't. And the other piece of it that's really hard to understand is the host, and when I say host, I mean the patient woman with cancer. response to that disease? How do you account for that woman's immune system, that woman's state of health, what we in the science call the tumor microenvironment, where the tumor is living? These are things that are really impossible to look at in the test tube. But these are really important interactions with the cancer itself. So that's why each woman's ovarian cancer is going to behave differently. And this is the idea behind personalized cancer care, the idea that we can genetically sequence your tumor and tell you which drugs your tumor is going to respond to. Well, that's great. But we're really not at a place yet where we can tell you, your immune system is going to respond in this way to this problem. We're going to get there. I have no doubt that we will. There's some really smart people looking at this idea of tumor microenvironment and host response. We're going to get there. The other point I want to make with recurrent, this is my mother and my grandmother. My family really doesn't like my slides. I have 2 sons too, and they get left out of this, but I talk about them when I talk about the HPV vaccine. Each patient with ovarian cancer has different goals, and we heard about some of those goals from the survivors earlier today. Your goal if you're 60 is going to be very different than your goal if you're 85, right? And when you talk about statistics for ovarian cancer, the other thing I tell my patients is, look, those statistics are averages that go from women who are 17 years old to women who are 90 years old. There's no way that you can apply those statistics to an individual woman. You can't. Your survival rate, if you're a survivor, is 100%. Who cares what the average survivor rate is, right? That's taking all comers and women who have different goals of care, women who are willing to undergo different sorts of treatments and different toxicities. The woman about when I'm talking to a patient about recurrent disease, first on my list is always observation, and I know that's scary. But sometimes observation or a treatment break, it can also be called, is the right thing to do. And I'm going to talk about that a little bit more with my next slide. Hormones, there are hormone treatments that work in the recurrent setting that can be non-toxic. Chemotherapy, biologics, and by biologics I mean the drugs that you've heard about, like the enzyme blockers, Avastin or bevacizumab, the PARP inhibitors, etc., that are not chemotherapy. Surgery, clinical trials, which we've heard a lot about, and alternative medicine. So when a woman is I have a story that I just want to tell you. I have a woman who I've been taking care of for a long time who has stage 4 ovarian cancer. And about a year ago, she had some disease in her abdomen that we could see on her CAT scan. And she had a lot of things going on in her life, bad things, and her parents needed to get moved into retirement. And we decided to do an observation period to see exactly what her cancer would do. And she's now been in observation for almost 2 years. No treatment, and her cancer has been absolutely stable. And that sometimes happens. And it's scary to not have treatment. I actually have her come see me once a month just to check in because she has a lot of other social issues, and we just talk just to make sure that she doesn't have any new symptoms, that nothing new is going on. But I guarantee you, if I had been treating her with chemotherapy, I would have
ISIS application in Ecuador. In Ecuador, a total of the 1140 patients in the world international patient in the BRCA mutation or cohort. The median progression free survival and the was 34 months in the very and the total growth on the 22 months in the control group and 95 confidence interval in the HRT comfort. It was the 31 99 month on the 25 month related on the interaction to the third population is a 23 5 months on the 73 months. Believe it led to higher incidence of the anemia and thrombocytopenia. One COVID is the was shot therapy and the world on the nasal nausea and the fat over time. continue my video.
In many ways, I would say that the paradigm of ovarian cancer management, it leads the way, and that's certainly been true in the earliest days with the development of the platinums, which were initially in ovarian cancer, paclitaxel in ovarian cancer, which became very important drugs in other areas. So yes, I think that what we're seeing in ovarian cancer will be seen increasingly in other tumor types. The concept in lung cancer 5 years ago of thinking about, gee, we have effective therapies, and that this might be more of a chronic disease process. 5 years ago, lung cancer, you'd say, you're crazy? But increasingly, we have effective therapies. We have chemotherapies. We have targeted therapies. We have immunotherapies, for example. How do you sequence them in lung cancer? What's best for that individual patient? Looking again, there, of course, we have a lot of data on the precision medicine approach. But yes, this chronic management. It'd be wonderful if I could say we could cure many more patients with many more cancers. That, of course, will be an ultimate goal. But until we get to that point, or maybe we won't get to that point, certainly not in my professional career or lifetime, we may still be very effective in managing patients through their cancer journey over an increasingly long period of time, measured in years, optimizing their quality of life, allowing them to do what is important to them in their lives. So that is a very worthy goal. So yes, what we're seeing in ovarian cancer, we are seeing in other tumor types.
In conclusion, the addition of the Veliparib is the third and the link carboplatin in the plant state, which continue my maintenance of the Veliparib and monotherapy and significant improvements, PF and C. It all occur in the woman with neurodiagnostic HG is C, including the heroin popular with hope biomarker selection. The means of the result of the cytoreductive surgery and the kosher independent, which and BRCA or ACRD mutation. The conclusion that its problem and the CLPM was independent on the return to carboplatin, but lethane the toxicity observed with and the Veliparib were consistent with unknown side effects proven of the Veliparib. Thank you for you.